Hello, my name is Dr. Francis Farraye. I'm a professor of medicine at the Mayo Clinic and director of the Inflammatory Bowel Disease Center at the Mayo Clinic in Jacksonville, Florida. I'll be reviewing with you now the identification and interpretation of mucosal disease activity and dysplasia in patients with inflammatory bowel disease. These are my disclosures. We all know that endoscopy is quite important in managing patients with inflammatory bowel disease. We complement the history, physical, labs, and imaging to make a diagnosis of IBD. Histology is essential in distinguishing IBD from infectious colitis, ischemic colitis, drug-induced enteropathy, and other etiologies. We also use endoscopy to assess disease activity and response to medical therapy, specifically mucosal healing, in a treat-to-target algorithm. And obviously, we use endoscopy for dysplasia surveillance and treatment. It's very important when performing endoscopy in patients with IBD that we include descriptors in all endoscopy reports to aid in clinical decision-making. What is the extent of disease? Is there continuous involvement versus skip areas? What does the terminal ileum look like? Is there erythema, granularity, friability, erosions, ulcerations? And we'll be going over this as we go over the various scores. It's quite important, especially at that first diagnosis, to biopsy both normal and involved segments in patients with newly diagnosed IBD. Now, IBD phenotypes should be classified according to validated classification systems. And the Montreal Classification system describes disease extent in adults with both ulcerative colitis and Crohn's disease. And in this figure, the Montreal Classification is reviewed. There's E1, E2, and E3 for ulcerative colitis, whether patients have proctitis, left-sided ulcerative colitis, or extensive disease. And for Crohn's disease, we have several different parts of the Montreal Classification. We have the age of onset, A1, A2, or A3, if it's less than 16, 17 to 40, or greater than 40. We have location, which is an L score, L1 for ileal, L2 for colonic, L3 for iliocolonic, and L4 for isolated upper GI. And then finally, the behavior. B1 if it's non-stricturing, non-penetrating, B2 for stricturing, B3 for penetrating, and we add a little asterisk of P if perianal disease is present. Now, we should work very, very hard to document endoscopic disease activity, and we should standardize this. So we're going to review for you now the MAYO, SCS-CD scores, and the Rutgers score. Now, we all know that the MAYO score has been around for a long time. It's easy to use in clinical practice. It's commonly used in clinical trials, with mucosal healing being a score of 0 to 1. And you can see in these four figures, MAYO 0, MAYO 1, MAYO 2, and MAYO 3. With friability present, that makes it a MAYO 2. So let's look at this first video showing a MAYO endoscopic score of 1. What you're seeing here is marked erythema, a lack of vascular pattern. You're seeing an inflammatory polyp at 6 o'clock in this image. And friability, if you were to rub against the mucosa, you can see some bleeding. The presence of erosions is quite important, and you use the presence of erosions to make something a MAYO 2. Let's now look at a MAYO 3 score. And in this particular score, what you're seeing is larger ulcerations, spontaneous bleeding. That's a MAYO 3. So now let's move on to the SCS scoring system. In the SCS scoring system, we look at size of ulcers, percent ulcerated surface, percent affected surface, and the presence or absence of narrowing. And this is reviewed in this particular slide. And what you do is you evaluate each segment of the colon and ileum, the right colon, the transverse colon, the left colon and rectum, and you score up each of the segments. So in this video, what we're seeing are large ulcers. They're about 2 centimeters or larger. The ulcerated surface is clearly more than 30%, and the affected surface is more than 75%. There's no stricture, and if you add this up, this is an SCS score of 9. Let's look at the Rutgers score. The Rutgers score was developed to assess disease activity after iliocolonic resection. In this particular video, what you're seeing, you can actually see a stricture. You can't get through the stricture, but you can look through the stricture into the neoterminal ileum. That's the anastomosis right there. And we're looking into the neoterminal ileum. We cannot enter the neoterminal ileum. This would be at Rutgers I4 score. If you use Provation, what you can see in this slide, you can use endoscopy writer options. And so what you're seeing here is a one-way and then another score to look at MAYO score, and a third score to look at the Rutgers score. So these are quite easy to use in your clinical practice. And I do encourage you to do this, as it makes it much more easy for your colleagues and other physicians to be able to follow what's going on in that particular patient. What you see on this slide is a review article that I did with my colleagues Jimmy Limdy from the UK, Mike Picco from Mayo, and it goes over all the endoscopic scoring systems, and it has videos. I'm going to change gears now and talk about dysplasia identification. In 2022, we know that most dysplasia in ulcerative colitis and Crohn's disease of the colon is visible using high-definition white light colonoscopy or image-enhanced endoscopy, and is rarely invisible. And in many cases, dysplasia in patients with IBD can be managed endoscopically. And what you're seeing here at the left part of the slide is a dysplastic lesion that was not endoscopically resectable. In the middle part of the slide and the right of the slide, two dysplastic lesions that were endoscopically resectable. So we need to use the correct nomenclature. The correct nomenclature, we need to stop using the terms adenoma-like polyp or daum, and we need to switch it to using all lesions should be described by a modified Paris classification. Lesions are polypoid if they're greater than 2.5 millimeters tall, and if they are polypoid, they're either pedunculated or sessile, as you can see to the left of this slide. If they're non-polypoid, that means less than 2.5 millimeters tall, they can be flat elevated or flat depressed. And finally, if you take a biopsy in the colon, you see no lesion and it comes back as dysplasia, that's invisible. So use the correct nomenclature. This slide goes over one way of describing colonic lesions. They talk about the 5 S's. Visible lesions should be described based on their size, whether they're in an area of active inflammation, what is their morphology, is the border clear, is there ulceration, and then include in your report how you resected the lesion. I was fortunate enough to be involved in the scenic recommendations from 2015, and this is an update, a review article that was written by Jim Marion from Mount Sinai. Basically, what they came to the following conclusions. High-definition colonoscopy is recommended for dysplasia surveillance. Dye spray chromoendoscopy with targeted biopsies. Sampling is recommended over white light endoscopy when using a standard definition colonoscope. And you have a number of different techniques. Dye-based chromoendoscopy, white light endoscopy, NBI, virtual chromoendoscopy with targeted biopsy are all acceptable modalities for surveillance when using high-definition colonoscopes. And the endoscopist should basically have training or expertise in the method that they're using. Random biopsies still should be obtained in addition to targeted biopsies in highest risk individuals, those that have PSC, previous neoplasia, active inflammation where you really can't use virtual chromoendoscopy or dye-based chromoendoscopy, and those with a scarred tubular colon. If you want to learn how to use chromoendoscopy, this is a nice video published in GIE in 2017. I want you to watch this space. There's some new things coming down the pike, a modification of the SCSCD score called the Modified Multiplier SCSCD, the use of intestinal ultrasound to assess disease activity. There's a score that our radiologists use called the Maria score, and AI augmented systems are coming. They've already been approved for polyp detection, and we expect to see them for detection of dysplastic lesions in patients with an IBD. And what you're seeing in this video is AI augmented dysplasia detection. A box basically opens up. You can see a lesion here on the right slide, the right part of the slide rather, and then you can basically do targeted bowel resection. So the take-home points for this lecture are to use endoscopic scoring systems when performing colonoscopy in patients with IBD. That's either the MAYO score, the SCSCD score, or the Rutgers score. Methodically describe lesions found on colonoscopy, and at the very least, please include multiple photos in your colonoscopy report. Use high-definition colonoscopes and complement with dye-based chromoendoscopy or virtual chromoendoscopy when performing surveillance colonoscopy in high-risk patients. Many dysplastic lesions can be managed endoscopically. Expect artificial intelligence platforms. They're coming to help you characterize disease severity and identify dysplasia. Thank you very much.